Hello, everyone, and welcome to the June 2025 UCLA Tarjan Center Distinguished Lecture Series. I'm Dr. Jasper Estabio, Director of Training for the Tarjan Center, and it is my pleasure to be here with you today. As we welcome you to our lecture series, we'd like to thank and acknowledge our co-sponsors, the UC LEND program, the UCLA Center for Autism Research and Treatment, and the UCLA Intellectual and Developmental Disabilities Research Center. I'd also like to take a moment to acknowledge the uncertainty and stress facing many in our Los Angeles and Tarjan community. Our hearts are with you, and please let us know how we can support you. A couple other reminders before we get started. Please do enter your questions for our speakers into the Q&A throughout the talk, and we'll facilitate discussion at the end of the presentation. Please also complete our evaluation survey to provide feedback and suggestions for future lectures. A link to the evaluation survey will be sent in the chat today, as well as in a follow-up email later this week. And with that, I'd like to now introduce our wonderful speaker. All right. Dr. Kelsey Oliver is an assistant professor of special education at the University of Hawaii at Manoa. She's a board-certified behavior analyst who started in the field of education as an inclusive preschool teacher. Dr. Oliver has a bachelor's degree in psychology, a doctorate in special education, and a postdoctoral fellowship in psychiatry and behavioral sciences. She is passionate about teaching educators, service providers, and families to utilize person-centered supports and evidence-based practices to improve quality of life outcomes for individuals with disabilities. Dr. Oliver has authored numerous research articles, a policy brief, and book chapters on topics related to family support, teacher training, and evidence-based practices for autism and inclusion. Please join me in giving a very warm virtual welcome to my friend and colleague, Dr. Kelsey Oliver.
Aloha, mai kako. Hello, everyone. Thank you, Dr. Estabio, for that lovely introduction. I'm very excited to be here with you all today to talk about our ECHO Autism Hawaiʻi program and some of the outcomes. It's a big passion project of our group, and so we're really excited to be able to share this information. So before we jump into things, I want to start with a funding acknowledgement and give Dr. Maya Mateus, who you'll see in a couple slides, a big shout out, as well as the Center for Disability Studies at the University of Hawaii. Our program is funded by an Autism Center of Excellence grant awarded by National Institute of Child Health and Development. We are also supported by a University Center for Excellence in Developmental Disabilities, so a UCED grant funded by the Administration on Community Living. And we wouldn't be able to do this work without that, so we are grateful. So let's talk about what our objectives are for today for this talk. So I'm going to start by introducing and describing the ECHO model. I'm then going to describe how ECHO was adapted and implemented for communities of educators and service providers across Hawaii. I'll also show data from sessions on the feasibility and acceptability of family-centered care strategies, as well as the program and the model of ECHO. And then I will show some outcome data from the post-session surveys at the very end of the program. And then we'll wrap up by discussing the future directions. So this is our hub team. As I mentioned, we have Dr. Maya Mateus kind of leading us all. She is a clinical psychologist, and she's also faculty at the Center on Disability Studies at UH. We also have Dr. Maria Kolik, who is an assistant professor in the special education department with me. And then myself. So I'm, as Dr. Estabio mentioned, I'm an assistant professor in special education with a focus on extensive support needs. And I also teach in the ABA program as well. So what is Project ECHO? So the model is an evidence-based, research-supported mentorship model. So this utilizes technology to connect a sort of hub of specialty content experts with generalist spokes across different urban and rural areas, with the intention to disseminate knowledge and provide guidance on common and more complex conditions. So one of the central tenets of the ECHO model is to move knowledge, not people. This means that the Project ECHO model differs from more traditional telemedicine in that this team of specialists mentor community providers who then provide the information and services and support to community members. So it's sort of a train the trainer model rather than us experts directly providing the services to the communities in need. So this approach allows service providers to connect with one another, to develop and maintain relationships, to build new skill sets through participation, and create this really dynamic community of learning and community of practice. The ECHO model is founded in some primary guiding principles. So a big one is the democratization of knowledge. So we want to provide an opportunity for our community of experts to openly share knowledge and resources and make this information more widely and more easily accessible to providers and families. And because ECHO is interdisciplinary, we really value that mutual respect of one another and non-exclusivity, meaning that we don't own our information and resources, and that we are stronger working together across our disciplines and areas of expertise. The original ECHO model was developed and implemented by physicians at the University of New Mexico. And that has been extensively researched and shown to improve health outcomes. So it's important that we implement the model with fidelity. So the degree to which it's being implemented as designed or as intended by the developers. Another one of the main goals is to empower educators and providers. And this is done through shared problem solving, positive communication, and active listening skills. And then this idea that all teach, all learn, where the knowledge of each ECHO member, not just the expert hub team, is seen as valuable and important. And finally, collective data and community-based research is very valuable to this model in order to best improve outcomes. So that's why we conduct the follow-up surveys at the end of each session and the program to help us make database decisions and figure out just how effective our program is for serving the needs of our community. Let's take a look at some of the outcomes of the ECHO model before we dive into the autism model specifically. So this model has been used for a wide range of physical and mental health disabilities, such as rheumatoid arthritis, diabetes, chronic pain, HIV/AIDS, hepatitis C. UH Manoa also hosts an ECHO Geriatrics and an ECHO Care Home program. So those are also part of our School of Medicine. And what research has shown is that primary care providers who were trained through the ECHO model offer equivalent patient outcomes to those who were trained as specialists in certain areas. Research has also shown that these programs can increase knowledge and performance and competence from participants, as well as their satisfaction with the program and collateral positive benefits for their patients and the people they're supporting. So now let's focus a bit more specifically on the ECHO model for autism. So in response to this immense need to increase accessibility of care and to disseminate resources for autistic individuals, ECHO Autism was initially developed by faculty at the University of Missouri in 2015. There are ECHO programs focused on autism in multiple states and across the world, actually. I met recently with some folks that were doing a program in Argentina. And so this is a widely used and a growing model. So there are currently 36 ECHO autism programs across the world, and this number is continually growing. And you see on the graphic on the screen that same learning loop where the the specialist team, the hub of experts, is supporting local care teams who then can support individuals with autism and their families. So you can see this is pretty important stuff, but it's especially important and significant in Hawaii for a variety of reasons. So for Hawaii specifically, there's really this significant need for effective sharing of knowledge and resources for autism service providers and educators and family members. And this is related to a variety of reasons. One being the physical geography of the state. We are very spread out and have many rural areas. And there's a big urgency here to build the capacity of community providers in these more remote or underserved areas. So you can see Hawaii is made up of 8 main islands, 7 of which are inhabited. So we have our communities spread across many areas across the ocean. Autism services and supports are especially important in this region due to the fact that children with ASD who are Native Hawaiian or other Pacific Islander have access to fewer autism resources per child compared to white children with ASD. So we can see some major discrepancies there. As one would imagine, and as I mentioned, the physical geography of Hawaii leads to having disproportionately low access to autism services in some areas. And there are many regions with no physical access to services at all, and families have to fly to the other islands to even be able to access services or to see a specialist, which you can imagine is very prohibitive for many families that just don't have the feasibility to do something like that, right? So here's an example in Hawaii. Let's look at some of these disparities related to behavioral services. So according to the Hawaii Department of Education, which supports all of the inhabited islands, right? We have one Department of Education supporting the entire region. As of October 2024, there are, across all the islands, 35 employees in the school system in behavior analyst positions, 17 employees in behavior analyst teacher positions, 123 board certified behavior analysts or BCBAs under the state ABA contract. However, there are 2,686 students across the islands who are eligible for IDEA services under the category of autism. So you can see there are pretty significant discrepancies just in this one area of service provision. Or as some people would say, the math is not mathing, right? We have a bigger need than our capacity. So in that case, the overarching goals of Echo Autism Hawaii are to really foster this community of practice. So the main, the main goals and the main tenets of what we're doing are to reduce disparities in access to autism services, more effectively disseminate knowledge and resources related to autism, and ultimately improve outcomes for autistic individuals and their families across Hawaii. More specifically, though, for this program that we ran as the pilot program, we want to increase provider knowledge and confidence with implementing family-centered practices across the lifespan. And I'll talk in a minute a little bit more about what specifically that means and that looks like. We also, because the need is so great and the number of service providers is so few, we need to increase access to this interdisciplinary network of providers. We really want to build this community of practice and have the capacity for providers to support one another and do so remotely, since being physically present is not always an option. We also aim to disseminate different evidence-based practices and resources so that providers really feel prepared and they feel confident in their skills and their knowledge and their ability to support autistic individuals. So sort of increasing that provider self-efficacy, that they know what they're doing and they're confident doing it. And then finally, partner with our community to do research. So using this community partnered research to collect data and analyze data to improve outcomes, not just the outcomes of our program and for program development purposes, but also for greater quality of life outcomes for the individuals that we serve. So these are the more specific goals of our program. How do we do that exactly? So our focus, as mentioned on this slide, was on family-centered care. So if you're familiar with Bronfenbrenner's ecological systems model, which is kind of shown on the screen here with this infographic, an individual's development is influenced by multiple systems that are all interconnected, from immediate surroundings, such as their family and their school or their classroom, their peers, things like that, to more broad societal contexts, such as the neighborhoods they live in, the service providers and the organizations that they're a part of, social welfare services, things like that. So there's all these factors interconnected and dynamically working together to impact the well-being and the outcomes of individuals with disabilities. So that we know this service provision and support occurs within these multiple contexts and settings. However, we also know that caregivers are usually the closest system to that individual. So they are the experts on their child. They usually spend the most amount of time. They usually have the most direct impact and influence. So it's really important to provide resources to service providers to understand how to support families and not just provide the services directly, but support the families who have a big impact on the autistic individual or the individual with disabilities, or any individual. They don't even have to have disabilities to fit into this model. So family-centered care involves families and professionals working together to support that well-being of the child and the family. And this is exemplified by both parties sharing their respective knowledge and skills to jointly achieve outcomes chosen by the family. And I'll share specifics on how we taught these skills in a couple of slides. But just quickly, I wanted to share some outcomes of family-centered care in general and kind of emphasize why this is important and relevant to the communities we work with in Hawaii. Family-centered practices are more likely to build mutual trust and shared effort in achieving goals. Family-centered care also increases caregiver self-efficacy and well-being. It contributes to increases in positive adaptive child behaviors and decreases in perceived negative behaviors. So it's not only beneficial for caregivers, there are also a lot of collateral benefits for the children. And family-centered partnerships are more likely to contribute to families viewing services as effective and contributing to their quality of life. So if families view services as being effective, they're more likely to engage in and continue engaging in those services, which has positive implications for their long-term well-being. So you can see how this ECHO model of training the trainers in family-centered care could really be beneficial. So how did we do this? We focused on, well, first we had to be trained on how to do this. So it's important to implement this model as it was originally designed, so fidelity of implementation. So ECHO Autism Hawaiʻi Hub team completed a 3-day training on the model from the Hub team at the Mind Institute at UC Davis. And our fidelity of implementation was scored by an outside observer who was familiar with the program and one of our internal research assistants. And our Hub team implemented all sessions with fidelity to the original ECHO model, which is important. and good to hear. So let's talk about what we then, oh, I think I skipped a slide actually. I didn't talk about the family-centered care, the most important slide, possibly. So these were the strategies that we used. All of the sessions centered around knowledge and resources that incorporated these ACE strategies, and we kept returning to these and having discussions about them. So you'll see that there's a lot of overlap between these concepts. We just love a good acronym in our field, so we kind of grouped it that way. And things like building an alliance, actively listening to the caregiver and conveying that partnership and communicating positive regard. And then under collaboration, giving suggestions, not directions, and asking for their input, as well as collaboratively planning for home and community practice. And then also empowerment, so acknowledging caregiver strengths and jointly identifying and problem solving through barriers, but empowering them to do that and feel confident doing that as well. Okay, we talked about fidelity of implementation. Let's move on to the program itself. So here was our schedule. I'll first talk about the structure of sessions, or I'll talk about the schedule of sessions, and then on the next slide, I'll talk about the structure, so what specifically happened during each session. So our sessions occurred every 2 weeks on Zoom for a duration of 90 minutes. And the session topics focused on, like I mentioned, how to provide those family-centered care strategies throughout the lifespan. So each session focused on a different age range, with the exception of the first session, which was just an introduction to the ECHO model and a general introduction to these family-centered care strategies. The didactic presenters, which I'll explain that in a moment, were experts in those particular topics, and they shared their knowledge and resources specific to that topic for the week. So the first presenters that just talked about the model and family-centered care in general were the hub team. So myself, Dr. Matthias, and Dr. Kolick. For the family-centered care in early childhood, we had a local developmental behavioral pediatrician, Erica Phelps, who has expertise in the diagnostic process and early intervention and things like that. For our family-centered care and school-aged children session, we had Dr. Naomi Chachera, who is a Native Hawaiian professor of special education in our department. She is also the parent of 2 autistic children, so she has a lot of insight on many, many different things. And finally, we had family-centered care for transition age individuals. And the presenter was Susan Wood, who is the director of Hilo Pa'a Family to Family program. So she has a lot of knowledge and experience with supporting families and individuals who are transitioning from high school into different settings or just sort of different adult transitional services. This is what each session looked like. So this was important because, like I mentioned a couple times, we wanted to implement the program with fidelity to the original model. So it was important that each session included each of these components and stuck to the general time frame that these components were meant to be. So we always started with welcomes and introductions. We usually had all of the same people. It was a closed cohort. So a group signed up and they stuck with the program throughout. But some days, some people weren't able to attend, or, we just wanted to refresh people's memories on who is who. So we would do a check-in activity, review any news or updates, ask folks if anyone had a case presentation to present for the next session, just sort of housekeeping things. And then the didactic presentations lasted between 15 and 20 minutes. So this is where the content experts that I mentioned on the previous slide would introduce and describe strategies related to whatever that session topic was, and always tie it back to family-centered practices. So this was sort of the expert that was providing training or sort of this didactic information. Then we moved into the case presentation, which lasted, again, between 15 and 20 minutes. These were real life case examples that were brought to us by ECHO members. So ECHO participants, if they had a case that was challenging for them or that they wanted further input on, or just to be able to kind of collaborate and brainstorm ideas, they would bring this case to the group, and there was a specific structure we used for having them present the case. And then they also presented some guiding questions to the group on what their main area of concern was or what they specifically wanted feedback on. So this was a big part of the program, as you would imagine. Then before we jump into giving ideas or suggestions or thoughts, this time for question and answer, about 10 minutes, was really important, just so we can get clarification from the presenter. We can ask really detailed questions to get specific information before jumping into recommendations, because it's likely that just by asking those clarifying questions, we can reduce unnecessary recommendations or things that have already been tried or things that have not been effective, things like that. So that was an important component, and our team learned to redirect any recommendations and have them postpone them until that specific section so that we could really get all of the clarifying questions and answers completed. Then we moved into those recommendations and considerations. So participants shared their recommendations, any certain strategies they are aware of, different community resources or things that they had come across. And this is where the interdisciplinary model really was beneficial, because some of our hub team, or some of our spokes, if you will, had access to resource and knowledge that people from other disciplines might not have ever heard of. And so it was really crucial to be able to share that information with one another and to make that more accessible and more known. And then we ended with a wrap up, which was about 5 minutes. It was a summary of the session, reminders of upcoming sessions, a reminder to complete the post-session survey, and things like that. So that's what we did every time. Let me tell you a little bit more about the case presentation, since that was kind of the crux of the program. So based on this principle of all teach, all learn, each session the ECHO participants would present, not all of them, we would have one case per session, but present on a case that they were working on just to receive that support and feedback. It was important that these cases were anonymized and did not include names or any really specific identifying information, which is especially important for confidentiality because our community across the islands is surprisingly small, and many people know one another in our field or know of the students or the clients that we're working with. So we just had to be very conscientious about that. So the case presentation involved first a case description. So this included the age of the individual, the diagnosis or diagnoses, whatever the service setting was, and whatever current services they were receiving. Then the presenter talked about different family considerations. So what language is spoken at home? We have a very, very diverse population across the islands. So things like family considerations and cultural considerations were really valuable to discuss. We had them talk about family composition, different support systems that the family might have in place, and who was the primary caregiver or caregivers participating in services. We also had them focus on individual and family strengths. We wanted this to be a strengths-based model as much as it was areas of need and support. We also asked them to report on current skill levels. So this didn't have to be specific assessments of skills. This could be a more general explanation of communication skills or academic needs or behavioral skills, anything like that. And then additional medical considerations. And this was a big one and often a big focus of our discussions were the service barriers. So common factors, triggers, different stressors, different environmental factors that might have kept the individual or the family from meeting goals or from getting services, things like that. We also had them present on previous strategies. So what has already been tried and how successful was it? And this is to help reduce the number of recommendations of things that the family or the service provider has already tried, really kind of streamline our discussions. And then the presenter talks about their focus. What is their primary area of concern? On what specifically do they want this echo community to provide support or ideas or input on? So really kind of guiding the discussion that way. And we consistently emphasize to our participants that this is their role, is all teach, all learn. So we wanted them to actively engage, be fully present, fully ready to learn. We really encouraged everyone to have their cameras on so that they had that interpersonal connection as much as is possible through Zoom or virtually. We asked them to minimize distractions, just sort of set aside this hour and a half of your time to be fully present with your community. Avoid reading and sending messages, doing other work, or multitasking. Share your knowledge because your contributions are invaluable and might be things that other members of the ECHO team are unaware of or don't know. And then do not share any protected health information. And then also being open-minded to diverse views. So learn from others, adopt the spirit of improving, not proving, value and respect all the perspectives, and be mindful of who is not in the room. To make sure our program was also appropriate and relevant for the communities we were serving, we wanted our approach to be culturally relevant and use culturally sustaining practices. So that's defined as work that not only respects and honors, but intentionally nurtures and expands ethnically and racially minoritized students' cultures. So these practices can uplift, center, and sustain Black, Latino, Asian, and Pacific Islander, and Indigenous or Native peoples' cultures. So it was very important for our hub team as transplants to the Kingdom of Hawaii to find ways to engage in culturally sustaining practices and to center the voices and experiences of the diverse communities living here. So to implement practices that are culturally sustaining, these are some actions we took to adapt eco autism for Hawaii specifically. So talk story is a Hawaiian idiom meaning to informally chat or share stories, often in a relaxed and intimate setting. And it's a way to connect with others and share experiences and build relationships. So we really tried to embody this concept throughout all of the sessions. We also know that connections to the land, to elders, and to the community are really highly valued in Hawaiian culture. So we wanted to embed these values into our program. So for our welcome and introduction activities, we always included something related to having participants share their aina, their land, and their kapuna, their ancestors or their elders or mentors that they were bringing with them that day to the learning space. And we can connect on a deeper level that way. We also wanted to understand the unique barriers and facilitators to service provision. So our sessions always included these interactive discussions on barriers to providing family-centered care in their work in Hawaii and examples of these ACE strategies or family-centered care practices in their work. Okay, so now you know a little bit about, or a lot about the program, hopefully. Let's talk about some of the outcomes that we saw. So we had 28 service providers registered on our Echo platform. We ended up having 22 of those 28 participating in the program, and there was an average of 13 participants per session. Our group included clinical psychologists, speech language pathologists, early interventionists, special education teachers, a director of an organization, registered behavior technician, and a service coordinator. So we had a pretty good range of professions for that interdisciplinary model. For those who completed the final survey, these were the reasons that they decided to join the ECHO model or join the ECHO program. The top one was a desire to learn more about autism. The next was a desire to increase networking and resource sharing with their colleagues. Next was a desire to learn more about family-centered care. And then we had one person respond with the desire to increase access to specialists and to interdisciplinary work, which is not that different from increasing networking and resource sharing with colleagues, but just more specific. We did have some attrition. So some folks didn't join all the sessions or might have dropped early on, which was not very many, but we wanted to get an idea of why that happened. The number one reason was scheduling conflicts. We intentionally did this program during the summer, middle of the day, during lunchtime, so that it would be a little bit more accessible to folks. But, scheduling conflicts come up, as well as personal and family issues. And one person mentioned the time commitment for the program. And one person had technical difficulties with online sessions. So these are all things we are cognizant of and looking into for future cohorts. After each session, they completed satisfaction surveys, so feasibility and acceptability and applicability. And then we had a post-program survey to evaluate the overall program. And these were all implemented on a 4-point Likert scale from strongly disagree to strongly agree. I'm going to share the survey items here just because they are a little bit small on the graphs. So this is what you can expect in the upcoming slides with the data. So after each session, we asked them about their satisfaction with the session. We asked them if their knowledge of the session's topic increased. We asked if their confidence with implementing the strategies increased. Strategies discussed were feasible to implement and acceptable to implement. Then we asked about the didactic presentation, if it was informative, if the presenter was engaging, and if it was clear and easy to understand. And then finally, the extent to which the case presentation was helpful. Then at the end of the program, we asked overall satisfaction with the program. We asked them to rate whether they would recommend the program to others. We asked about our ECHO team creating a supportive learning environment where they felt comfortable expressing their questions and ideas. We asked if their knowledge of family-centered practices has increased as a result of the program. And the data look really good. It's very encouraging. So I'll show you each session and then the overall post survey. So this is for session number 1, just the intro to the program and family-centered care. And the graph shows the number of participants who responded agree or strongly agree. Fortunately, no one responded disagree or strongly disagree. So we see really, really positive results and many, many participants reporting that they strongly agree with these statements, especially the end ones about the didactic presentation, that it was clear and easy to understand. So that's really encouraging. This was session number 2, early childhood, and we did have 2 people state that they disagreed with a statement about their confidence implementing the strategies today has increased. We looked into this and we think it might have something to do with the type of service provider. So the presentation focused a lot on accessing diagnostic services and the early intervention process and things like that. But many of the service providers were not in that field or did not have direct connections to early intervention or to diagnostics. And so we think that might have had something to do with it. But overwhelmingly, the rest of the data, folks strongly agreed with the statements that they were satisfied with the session, that the didactic presentation was informative and engaging, and that the case presentation was helpful. And it seemed like many people said the strategies were acceptable to implement. This was session 3 for school-age children. Again, really, really encouraging results. Everyone strongly agreed with a few of these items, particularly my knowledge of the session topic has increased. The didactic presentation was informative and clear and easy to understand. We didn't see anyone disagreeing with any of the statements here. Confidence has slightly fewer number of people saying that they strongly agree, but still very positive results. And finally, transition age individuals. So this follows a similar trend as the previous slides there and the graphs we saw for the other sessions. So overall, our participants, all of them, agreed or strongly agreed that they were satisfied with our program and that they would recommend the program to others. And it was really great to see that they strongly agreed that our team created that supportive learning environment for them and that they felt comfortable expressing their questions and their ideas, since that is such a critical part of this model, people being able to share their thoughts and ideas, and that their knowledge of family-centered practice increased because of the program. So this is really encouraging. It's not perfect. We have a lot of things to continue to work on and to continue to collect data on. But for a pilot program and to start this off, this is really, I keep saying encouraging, but encouraging is accurate. This is great to see. So some of our conclusions: the content in the program was well received by participants, and Echo Autism Hawaii has this potential to really bridge service gaps for autism providers in various underserved or rural or remote areas. And we know that culturally relevant approaches are really important on the islands and elsewhere for really effectively disseminating information and resources. So our next steps, we have a manuscript in preparation on this pilot study to submit to a research journal. We just presented the pilot study data that you saw today at the International Society for Autism Research back in May. And we have cohort 2 in the works, so that'll be happening this fall. We are going to do a much more in-depth study with pre and post measures and more statistical analysis and analysis of the networks, so how many people they are actually, our providers are then reaching. So we have IRB approval for that, so stay tuned. Maybe in a year or two, we'll have some more data to show you. And then we'll be expanding our model to additional topics. So we want to do an Echo Autism specifically for Ohana and different family members. And we've been looking into doing one on inclusive educational practices, which is another challenge on the islands. And with that, mahalo nui. Thank you so much for listening to this talk. And I welcome your questions or thoughts or feedback that you have.
Great. Well, thank you so much, Dr. Oliver, for that very important and informative talk. I know I'm still thinking through so many of the different aspects of this program, and I'll give our audience a moment to type those questions into the Q&A. And so I'll just start off with just some reflections. I love the kind of mantra of the ECHO model of moving knowledge and not people. And I found that to be especially valuable when you're logistically and physically separated. We have had to adapt and to make a lot of changes into how we deliver services. And I think that, necessity requires some innovation. So I love that implementation there. I also love that all teach and all learn model where we're all here to learn together, to, as you said, democratize knowledge, and to put together our resources to better support our communities. One of my first questions is, in terms of some of those cultural adaptations, if there were some surprises or things that you found to enrich the program that maybe you weren't expecting.
Yeah, that's a great question. It was actually very endearing and really helped to build those connections with one another, to hear about their aina and the people who are important to them, their kapuna, because people started to connect with one another and say like, hey, I'm from my Waimea. I was born and raised there. Do you know blah, blah, blah? Or like, just finding commonalities among one another in the places that they're from and that connection to those places. And just the commitment and the dedication to carrying on the legacy of people that had mentored them. So a lot of people talked about their kapuna who taught them to care for others and had this core principle, this core foundation of caring for one another and caring for the community. And so that was really not surprising, but really wonderful to see. And I think was a really important part of building this research network, because we're sitting up here in our ivory tower and, so enmeshed in the research world that it was important for us to step outside of that box and to really connect interpersonally with our community and the members of ECHO. So I think they felt that as well.
Absolutely, right. Truly embodying that community partnered work. And I imagine that as a transplant, that really helped enrich your knowledge and just understanding of how communities are interconnected and their background knowledge too. So all teach and all learn. I'm seeing a question here from one of our audience members about what strategy stood out to you as most liked by the participants. And anecdotal is fine.
Yeah. So I'm assuming we're talking about the family-centered care strategies, most
I
liked.
believe so. Mhm.
I think collaboration with families. So asking families their input and having families guide the discussion on what they wanted and what they needed. It seemed like there were many of our service providers were excellent at doing that, but that seemed like there were also a few aha moments where people realized that they could have the families lead even more, and that it was a true partnership instead of just sort of telling them what to do. I think that was a big one. I think just connecting to resources in general. So just being knowledgeable about what's going on in different parts of the island and knowing what our quality services that are very person-centered, and being able to relay those effectively to families. So just the communication piece, I think, being able to clearly and efficiently communicate to families with that active listening component of what these families actually truly want and need. So hopefully that answered the
Right.
question.
I think so. And I think, uh, we've been friends and colleagues for a long time, but I think that's something that continually comes up when we work on projects like this is um, not that people need permission, but oftentimes I think providers feel like they need that permission to not be so blank slate. And clinical, however we use that word, is that you can be a real human being first in your approach to working with families. And sometimes they need a little bit of a nudge to say, actually, this is what we expect and what we want more from you, and what the families and people that you work with actually want more of from you.
Absolutely. And there are many cultural considerations with that many of the diverse populations across Hawaii view the experts as experts, right? They there isn't this sort of back and forth collaboration. We're all on the same page. It's these people are giving me training and information. I listen to them. They are, they are knowledgeable. They are the authority figure on this. And that's just not going to work as effectively as these collaborative partnerships where we kind of break down that power dynamic and make it a more even playing field, and that families feel more empowered to speak up.
Right. Like there's no hierarchies here. We all have different aspects of knowledge and expertise. And it really is about partnering together so that way we can best serve our shared values and our shared goals.
Right.
From your perspective, and I know, right, we have this pilot study and cohort 2 is upcoming, but were there any barriers to some of the implementation that were either unexpected or maybe expected?
Yeah, I think physical access to things. There are some families in some areas that there's no internet access. They not only can they not physically go see a provider, but even telehealth is not an option or not a feasible option. So I think our community had some discussions on how to get creative with providing those services. And sometimes it takes driving out to them, like us traveling to those locations, which is also challenging in many ways. But in order to effectively get services to areas that are geographically distant, I think that was one of the biggest barriers was geographical distance, the lack of accessibility for a lot of these many services are expensive, and insurance doesn't cover a lot of these things, or families have to jump through a ton of hoops just to get that coverage. So that's not unlike what's happening on the continent as well. But here in Hawaii, it's even more pronounced sometimes because of the geographical distance and just the limited availability of service providers. We have far few, as you saw on that slide about behavior analysts and behavioral services, we have far fewer providers than the need. So all of those kind of come together as different barriers that we need to work through.
Right. I think oftentimes there's conversations about service access. And then here we're really seeing, oh, it's compounded by literally the geographic location as a barrier. I think for us here in Los Angeles, it's oftentimes this both and of service access, but also service utilization. And that's something that I've been thinking about a lot is we have lots of services, we have more service providers, but there's still these barriers that prevent people from accessing the services that we have available.
Yeah.
Kind of jumping off and building from that question, were there some things, whether it was aspects about the providers or the systems that they work in that were facilitators for the uptake of participating in this ECHO model?
Yeah, I think just those so if we're thinking of implementation science, right, looking at the different factors of why a practice is implemented or sustained or not implemented and sustained, we look at things like attitudes, beliefs, knowledge, self-efficacy, things like that. And I think our group had a really high level of positive perceptions that they can get this stuff done. Like they were dedicated, they had beliefs that this was important, and they were very committed to being a part of the program and learning more to make this happen. And I think that is that's a huge facilitator to have people who are so invested in the success of this type of project that they are going to implement strategies and they're going to think outside the box and they're going to, search their communities high and low to find the resources that they need. So I think those personal characteristics like the attitudes and beliefs and perceptions really make a big difference.
Absolutely. I think You're reminding me, not on a systems level, but if we're going back to our Bronfenbrenner systems of care, we see that on a family level too, that one of the strongest facilitators of long-term outcomes for individuals with disabilities is parent optimism, and not just optimism in terms of positivity, but their optimism in ability to access and navigate services. So I think we see this parallel with the service providers as well of like, I have that grit and I'm going to roll up my sleeves and I'm going to figure this out, no matter what it takes.
Absolutely. And that component of those ACE strategies, that empowerment, is crucial for that, for really building families up and helping them to recognize that they have the capability to do these things, that they are the experts on their child, and we can support them in getting them to where they need to be. But they really have, like you said, that grit, right? That you can get stuff done. So that empowerment piece was important.
We heard a little bit more about next steps with the project. Any adaptations or changes that you're particularly excited for in cohort 2?
Yes, so it can be challenging to get participants to present case presentations for a variety of reasons. They might be nervous, or they might not think it directly applies, or they might not have the time or capacity to put something together. So we have networked with some other and communicated with some other eco autism programs who had strategies to increase the likelihood of folks presenting a case presentation and to kind of encourage that. Also things to address attrition. So things like providing certificates of attendance, either for each session or for the program overall, that they can take back to the organization they work for and have a concrete demonstration of the training that they have completed. So it's really sort of fine tuning a lot of the components and learning from other ECHO programs. And yeah, I think just brainstorming additional topics and figuring out more about what our community needs. The family-centered care model was a really well-received and highly needed program. So we'll be implementing that same program, but we are going to continue gathering more in-depth information from our participants and through that research project on specific barriers, specific facilitators, so we can go about it in a more systematic way, and really research those, as opposed to just having those be discussions that occur during the program, which are very valuable as well. But we want to be able to kind of quantify those things and make some database decisions. So,
Right, very exciting. And I think that's also one of the most exciting parts about doing this type of work is because you are focused on culturally responsive practices, family-centered care. It's very iterative, meaning that we're constantly adapting, changing, refining, hopefully making it better because people's needs constantly change as well.
yes, very true.
All right. Well, thank you again, Dr. Oliver, my dear friend Kelsey, for being here and joining us today for our very last lecture of the 2024 to 2025 academic year. Please feel free to take down Dr. Oliver's contact information. The slides and the recording for today's lecture will be available on our website in a couple weeks. Please also complete our evaluation survey so that way we can continue to provide wonderful lectures like this in the coming years to come. I also value that feedback so that way I can be responsive to our audience and what kind of topics you are interested in. If you would like, our audience and Dr. Oliver, you're welcome to stay for our Tarjan Center Research and Resource Exchange, where our wonderful colleague, Steph Tuazan, is going to be joining us to share a little bit more about our special care dentistry program. But thank you everyone for being here. And I will hand things over to Steph to talk about special care dentistry. Thank
Thank you all.
you. That was a great presentation, Dr. Oliver. Again, my name is Steph Toison. I am a licensed clinical social worker with the UCLA School of Dentistry Special Patient Care Dental Clinic. In my role here, I support patients and families who are trying to navigate care in our dental clinic. And in particular, we see folks who have special healthcare needs, meaning that we often see folks who have intellectual and developmental disabilities, as well as are seen as medically complex. And I say medically complex in bunny ears because, for some of the folks that we see, they are often denied care out in the community because the dentists in the community don't feel comfortable treating them due to their medical complexity. And I say again in bunny ears because that's not really a standard definition right now across the board with different dentists and healthcare providers. For example, we could see some folks who have cerebral palsy or Down syndrome. And again, for us, they wouldn't be considered medically complex, but for a dentist out in the community, they might feel a little bit nervous or uncomfortable and would refer to our clinic. Because we are one of the few dental clinics that are still providing this care in Southern California and also accept Denti-Cal or the dental insurance for Medi-Cal, our wait list is very, very long. So to become a brand new patient in our clinic, our wait list right now is about 2 years. And again, it's not because we are intentionally doing that. We are trying to see as many people as we can. Our clinic is very small. This is really a multi-system issue of how do we increase access to care? So the other part is with our clinic, we predominantly see adults. So if you yourself or if you have a child who's 16 years or under with special health care needs, hopefully you are still able to access care. So for example, in LA, that looks like that could be Rancho Los Amigos, Children's Hospital of Los Angeles, or there are also more pediatric dentists who again have this type of comfort and do still have the capability to work with folks with special healthcare needs. So I'm hoping that if you are 16 years and under, that you are still having access to care. But again, once someone turns 18, there is a lot more limited access, unfortunately. And so a couple things I wanted to highlight today for folks who hopefully there are folks on the call right now who haven't been having issues in finding a dentist, but I wanted to highlight a couple of resources today in case there are folks on the call who live in California and are trying to find a dentist. So let me just share my screen. Okay. So I'm also going to drop the link in the chat because it is a little bit harder to find our website online. But if you Google UCLA special patient care or UCLA hospital dentistry, then hopefully you'll be able to find our website. But there are a couple of things I wanted to, again, just make sure to note for folks here. So this first resource I wanted to share is for anybody, whether you're pediatric or adults, and if you are navigating dental care. So something that we are trying to do in our clinic is try to kind of like branch out our resources and to kind of offer our website as a resource for that. So if there are anything that you have suggestions on or any requests about, I would love to hear those as well. You're definitely welcome to either drop it in the chat now or to send me an email, and I'll give my email at the end of my discussion today. But again, with our website, we have just kind of like a quick overview of what we offer in our clinic. A lot of folks look for care in the OR because maybe that's something they received in the past, but it isn't for everyone who comes in because we try and see what is the need of the person and seeing how can we best meet that need. Is it in the OR setting or the operating room setting, or is it here in our clinic where we have different levels of sedation or medication that we can give to help have someone be more comfortable for their treatment. So if you go into our website, there is a menu button there where you can see for patients.
Under here, we have a few different resources that, again, we are slowly building out so that way we can have more information for folks who are interested. But the one I want to highlight is this piece right here for desensitization resources. So we have videos that we created that are both accessible in English and in Spanish as a way to introduce folks who maybe it's been a while since you've been to the dentist, or maybe you are starting to go to the dentist. But we're hoping that these videos can be a great free resource for folks to kind of see, what is it that it means to go to the dentist, right? And we know that for folks coming in, I know for me, the dentist is not my favorite place, and I'm also anxious when I go. And so this isn't an uncommon experience, but we're hoping that with the desensitization videos that this is something folks can watch, start to get familiar with, so that way it won't be as new or uh, you know not as much information out there, because we know that the more we can understand something, the more we can see something, the less anxiety producing it is, the less unknown it is. So we're hoping that by folks seeing these videos or just having access to these videos, that we can start to see people feel a little bit more comfortable and confident in coming to the dentist. And this, again, doesn't mean that you have to come to our clinic for. This is kind of like a general of what you might see at a dentist, even if you go out to somebody in the community. So I definitely, again, just wanted to make sure to share this resource for folks. And again, it's for any age. The other resource I wanted to make sure to, and we have some other information here too, in case that's of interest, but the other information I wanted to make sure to discuss. So most folks, if you have private insurance, meaning if you have like Delta Dental or a PPO insurance or an HMO insurance, I would first suggest to definitely call your insurance, and hopefully they do have a few, maybe two providers who are able to provide care. But for folks who have been calling, the list of dentists that they've seen or been given by their insurance, and they haven't been able to see anybody where, they make an appointment and the dentist says, oh, I'm not comfortable seeing you, go to UCLA or go see, somebody who has hospital dentistry or can treat you in the OR. There's a resource I wanted to make sure that you all know about. So this is if you also have Medi-Cal or Denti-Cal insurance. And I'm going to drop this link in the chat as well. But with this information here, so this again is not something that's associated with UCLA specifically or with my clinic specifically. It's more around if you have Medi-Cal, dental, or Denti-Cal, and you have been trying to find a provider to give you care, but you have not been able to. Maybe it's because of where you live, or again, because the provider doesn't feel comfortable with your medical history. You can ask either your regular doctor, primary care doctor, your specialist, if that dentist that you last saw is open to seeing or is open to doing this form, or even if you have a social worker with your primary care doctor, they can make this referral for you. Unfortunately, though, you cannot make this referral yourself. This has to come from a medical provider. But basically, what this form does is that if, again, you're having trouble finding a dentist, that you can have your provider fill out this form, and Denti-Cal or dental, Medi-Cal dental will look at the referral, maybe within 2 weeks, give you a call and say, hey, I got this referral from your doctor, and I wanted to help and see if there's something that I can assist with helping you find a provider. So what they try to do is look for, especially again, if you're in kind of all over parts of California, they'll look at where you live and kind of see, okay, what are the diagnoses that you have? What's the concern around having access to care? And they can try and see what referrals might be available closer to where you live for a dentist who might be able to provide treatment. They'll also ask too if you need assistance with maybe transportation or around having support during your appointment. If maybe you English is not your first language, or if maybe sign language is how you communicate. So they can also try and see if maybe there is a interpreter that can be present for your appointment. So that way, again, we're reducing the barriers towards access. But again, this particular form has to be submitted by a doctor, social worker, caseworker. It cannot be submitted by yourself. But this is a new-ish resource that I've seen in the last year or so that has come up. And especially, again, most dental clinics don't have a social worker as part of their team. And Denti-Cal Case Management still calls me as well. But this I've seen can be very helpful in helping folks access care if they're having a hard time finding a dental provider. And if for folks who are like, well, I, appreciate this information, but I am not too far from UCLA, or maybe you are far from UCLA, because we see folks again from all over Southern California. People come up from San Diego, people come as far as Fresno, the border around Arizona and Nevada. I even have folks that come in from Nevada to come and get care with us because, again, like just so many dental providers out in the community really don't feel comfortable with this. So if you are a regional center consumer, you can also try asking your case manager with regional center if they have any referrals for any dentists. I know that most regional centers try to have like a dental case manager or a dental caseworker who tries to build more relationships with dentists out in the community, where they can also potentially help provide some payment if that's of necessary, but they don't try to. But again, they do try to see how can they reduce some of those barriers and increase that access. I think last time there was with the resource share, it was on the, what's that program called with regional center where not supported decision making, but where they have funds where if folks they have a certain amount of funds and they can use it towards something like dentistry, if that's self-determination program. Thank you. So with the self-determination program, that if folks have a little bit of money from that program and want to use it towards accessing dental care, because it can be very costly if you're not able to use your dental insurance, because there's also different types of dentistry that you could have access with if you do need sedation. Many dentists out in the community, when they are providing dental care and you need sedation, do so with a dental anesthesiologist. And usually dental anesthesiologists are not covered by any insurance. And so something that regional center, whether it's through your case manager or with the self-determination program, that can often be used in support of paying for a dental anesthesiologist if that's what's recommended for care. But those are, again, potential options if you are looking for a dental provider. If you are coming back to us, though, and looking to see, because maybe you are on the wait list for example, like Rancho Los Amigos, or maybe you are 17, 18 years old, about to turn 18 and about to age out of pediatric dentistry, and you just want to get on our wait list, especially since, again, our wait list is about 2 years right now. You would again go back to our regular homepage for our clinic. And the other thing too is if you are looking for our clinic, you really want to ask for special patient care or hospital dentistry. Because we are in the School of Dentistry, there are 5 floors of dental clinics in the school. So if you were to call the main line and say, hi, I'm looking for a dentist, you would have a really hard time finding someone to support what you're looking for. Because again, since we have so many dental clinics, we don't really have like a way to specify where you can go if if you're just kind of asking a general question. So if you are specifically looking for our clinic, you want to ask for either special patient care or hospital dentistry, so that way you can get to the right person. Or again, if you have questions around who that might be or what care you might be looking for, I'm happy to help answer some of those questions as best as I can. I often do for folks who are on our wait list or looking for care. So if you do make it to our webpage again, and you want to scroll down, this is my direct number here, as well as my email. And if you do have questions for me, I'm happy to help answer. Just give me a little bit of time to get back to you, because I am typically only here in the clinic on Mondays and Wednesdays. So if I have some delay in getting back to you, just know it's usually just me right now. So I try to get to everyone who reaches out to me. But if you are interested in getting onto our wait list, on again our homepage, you'll see this link here where it will take you to our new patient request form. And I will also drop that into the chat just in case. And on this form too, if you wanted to have it in a different language, like Spanish, for example, you're more than welcome to also click on that and have it changed into Spanish if that's easier. But generally, if you, again, want to become a new patient in our clinic, every new patient has to go through a screening appointment. And part of the screening appointment, again, is that it is about an 18 to 24-month wait right now. And if you are on our wait list, I do try to check in with folks just to give them an update about where they are on the wait list. And again, if I'm seeing maybe there's other information that you put on your request, I can try to connect you with other dentists in the community that might be able to work with you, or if there's any other questions that come up. But this is, again, how you can get added onto our waitlist, because I know that is a question a lot of people ask me. And in terms of another top request that I often am getting from folks is kind of around just how to just kind of navigate their dental insurance. So with folks who have Medi-Cal, every Medi-Cal member has, anyone who has full scope Medi-Cal does have dental insurance. What type of Denti-Cal do you have? That is also kind of just depends on what your Medi-Cal is. But if you wanted to see kind of what's your Denti-Cal information, or where else can you see for a dentist, especially again, if maybe you don't necessarily have more of these like more complex dental needs and you are just looking for a dentist because it's been a while and you do have Medi-Cal. Again, currently, while especially this year, I would just really highly recommend that if you have Medi-Cal and you have not seen a dentist, to try and see one this year, because that might be one of the benefits that are cut in the years to come. So again, just as I know of today, please try to get connected with a dentist if you have not in the last 6 months to 12 months. But smilecalifornia.org is the Medi-Cal Dental or the Denti-Cal website where you can find resources around finding a dentist. They also have some videos and kind of guides for all ages. And I know that Medi-Cal is also pushing for Denti-Cal to not just be what's called fee-for-service or straight Denti-Cal, but that if you are coming to our clinic, we only accept fee-for-service Denti-Cal or straight Denti-Cal. But they are starting to offer, like for example, if you're in Sacramento, you wouldn't have fee-for-service Denti-Cal. So there's supposed to be more providers in theory that are within that program if that is something you have. But again, if you're not sure what you have, I would just say to contact Denti-Cal to see, which version do you have, and if you haven't been able to see a dentist, to try and find a dentist this way. And if let's say you do find a dentist and they are trying to give you care, you're trying to work with them, but they say, I can't work with you, or you're too medically complex, then at that point, again, you're welcome to get onto our wait list, and we'll try to work through it as fast as we can to get to you. But if you are able to see a dentist out in the community, please try, especially again, while we still have dental benefits with Medi-Cal this year. Does anyone have any questions, or is there anything that we wanted me to go over a little bit more in depth about? I just wanted to see, let me see if I can stop share for a second and look if there's any
I welcome
questions.
our audience to type in those questions into the Q&A. Thank you so much, Steph, for sharing those wonderful resources. I know I, as a clinician, get lots of questions about special care dentistry, so I was taking notes here on my end. And thank you again for sharing all those resources.
Sure. I'm also going to put my email in the chat for folks too. Again, I try to do the best I can to reach out to everyone who responds or who reaches out to me. So if any folks have questions, you're more than welcome to reach out. And I'm putting my dentistry email. It is HIPAA compliant. So if you did share anything personal about your medical history or your dental history, you can send it to this email and it'll be okay.
Well, thank you, Steph, for sharing these wonderful resources. To our audience, if you're interested, please do take Steph's email address down so that way you can reach out and contact her. Lastly, huge thank you again to our wonderful speaker, Dr. Oliver from the University of Hawaii at Manoa, for sharing about the Echo Autism Project. Thank you all for a wonderful year with this year's lecture series. We hope you enjoy the summer, and we look forward to seeing you again in the fall. Thank you, everyone. Bye.